Dear friends, introducing SICOT Pioneer, Programme of Innovative Orthopaedic Networking, E-Learning, Education and Research. What is SICOT Pioneer? A stratosphere built up of cloud and web-based infrastructure that enable communication, storage and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices.
Good morning, good afternoon, and good evening, ladies and gentlemen. I'm Gaurisan Tevendran, Consultant Orthopedic Surgeon from Singapore and Program Chair for SICOT. And it's a pleasure to extend a very warm welcome to all of you from SICOT Pioneer, logging from the various corners of the world. Today's event is unique. It is an inaugural collaboration between SICOT and AO Trauma on our virtual platform. Further, today's event will mark the beginning of 5 successive, very topical themes between AO Trauma and SICOT, featuring hip fractures, intermedullary nailing, long bone fractures, and various complex hindfoot fractures, to name a few. A personal note of thanks to Michael Reddy's and the AO Trauma Board for facilitating this collaboration. Kickstarting this event on clavicle fractures, we have privilege of 5 different global faculty from all world-class trauma surgeons to sketch out the different controversies surrounding clavicle fractures. The webinar today will be chaired by Professors Christophe Papet and Hatim Said. Professor Papet is a professor and chairman of the Department of Trauma Surgery, University Hospital Zurich. Chris was also our previous chair of the SICOT Trauma Committee and continues to support and lead various trauma events on our virtual platform and the physical congress. Thank you, Chris, for helping make this webinar a reality. Hatim is a full professor at the Asuit University in Egypt and is our very own chair of the Finance Academy and treasurer of SICOT. Hatim's visibility on various SICOT educational events span over a decade, and I thank you, Hatim, for helping put this event together today. We at SICOT Pioneer strive to make every one of these sessions as interactive as possible. For the global audience that's watching us live today, the webcast on SICOT.org, please post your comments and questions in the discussion box as we progress through this event today. The moderators and our panelists will pick and choose the right questions to discuss them as we go along, and also at the end during the discussion session. And on that note, ladies and gentlemen, I hand over to our moderators today, and thank you once again for being on this virtual platform with us this evening. Hatim, over to you.
Thank you, Gao, and thanks very much for putting in Pioneer actually with Vikas. You've done a great job with that, and we're very glad of these activities. So I'll start by sharing my my presentation. So thank you everyone for joining us. This is as Gao has mentioned, this is the first webinar, first one between AO Trauma and the SICOT Pioneer, one of 5 webinars to come. So today will be moderated by Hans-Christoph Pape from Switzerland and myself, Hatem Saeed from Egypt. We have very distinguished faculty with us from Simon Lambert. And Simon is a shoulder and elbow reconstructive surgery with a long history of shoulder surgery, over 2 decades with the AO. He's currently the chair and technical commission for the Upper Extremity Global Expert Group. He is also involved with the editorial college member of the AO Surgery Reference and involved with AO Recon and AO Trauma faculty and the clinical founder of the OS app. We have also with us Frankie Leon, which he's an AO senior trustee. He's an AO faculty. He is the SICOT Education Committee Chair and the SICOT Trauma Subcommittee member. We have Terry Axelrod from Canada. Terry is an orthopedic upper extremity and reconstructive surgeon working in a level 1 trauma hospital in Canada, and has been involved with AO trauma in North America and worldwide for decades, and he enjoys all parts trauma related to that. So with this, I want to proceed. Today, our talks first one will be by myself, and it will include the middle third clavicle fractures, decision making, whether conservative versus surgery. This will be followed by a talk by Simon about implant selection and positioning. Then Frankie Leon will give us a talk about lateral clavicle fractures. Terry will follow that with a lecture how to approach and manage complications of nonunion and malunion of the clavicle. And the final one will be about combined injuries by Chris Pape, about the floating shoulder and combined clavicular fractures. So to start my talk, which is about mid-shaft clavicular fractures, decision-making, conservative versus surgery. So I want you just to take a minute to think about clavicle fractures and how you've been managing them, and whether you've always fixed them, you've never fixed them, but I'm sure the majority of you have sometimes fixed them. And the real question is here, when do you fix them? When did you go for fixing? And what we want to get out of this talk is how to decide which ones will do well with conservative and which ones need to be operated on. So just to take you slightly back about the history of clavicular fracture treatment, the first description of clavicular fracture treatment was in the Edwin Smith papyrus, and that's been discovered 2,630 years BC. And they describe 48 cases, but they come to a specific case where they describe a fracture of the collarbone, and they describe that you'll find that it's shortened and out of alignment, and this is something that you should manage. And they describe the principle of management is that you lay the person on the ground, you put something folded in between his shoulder blades, and you pull it out until it goes back into place. And if you think about it, that has not changed till now. So this is what they've been doing thousands of years for non-operative treatment of the fractured clavicle, and it still works very well till now. So what we're going to talk about is the mid-third clavicular fracture. As you know, it's the commonest fracture part of in the mid part, and it's about up to 80%, followed by the lateral third and small percentage with the medial third. So we're going to mention the assessment, when to operate, and some of the outcomes of managing these mid-shaft clavicular fractures. So the big question is X-rays enough? So most of us will do an X-ray, and we did a poll pre-webinar, and the majority of the people do only an AP X-ray. Maybe about 20% do an AP plus a caudal view X-ray, and 25% do a CT also. So do you always do a CT? Myself, not always, but I always do 2 views. And the reason that this study showed that shortening will look very fine on an AP X-ray, but not the displacement. Shortening is easy to see. For displacement, you need a different view. So the CT can show up to 20% difference from the AP X-ray and up to 11% difference from the caudal view. So if you're going to do only X-ray, it's important that you do an X-ray AP plus caudal view 20 degrees. Now, should we operate or not? And a lot of studies have come up to tell us about the results. One of the earliest that changed a lot of the practice was the Canadian trial, 8 RCTs, 130 patients, plates versus sling, and they found that it's better constant score dash satisfaction with operation, less malunion and non-unions, but of course, when you operate, there's a chance of hardware removal. Newer trials also came up in 2017, the Clavicle trial, multi-center covering 300 patients, follow-up for 9 months. The non-union is less than 1% for surgery and non-operative 11% in mid-shaft clavicular fractures may end up with non-union. The constant score and DASH score, the better with surgery, and some of the non-operative, only 11% went on to continue with surgery in those 9 months. This study looked at the difference between the adult and the pediatric adolescent group for mid-shaft clavicle fractures. Systematic review of meta-analysis comparing both groups. Almost 500 patients were covered, range up to 18 years. And they found that the union rate is actually equal. There's not much difference. The PROM and the quick dash is also equal. Slight improvement of return to activity and constant score. So this represents a slight difference from the adult group, that the non-union rate is similar in operative and non-operative ones. New studies also systematic review meta-analysis of 1,000 patients of plating, almost 400 patients of nailing, and 600 patients non-operative, 1 year follow-up, and they compared the results. Union rate is up to 96% when you operate. Non-operative, again, roughly 11% non-union in the non-operative group. And if you take plates only, the union rate goes up. And if you take the anterosuperior plate, the union rate reaches 99%. So that shows the highest level of union rate. Meta removal is similar in all operative techniques. And they looked at the dash and constant score. For operative, it is better than the non-operative, but did not reach the MCID in those scores. It only reached MCID in the anterosuperior plate. So the anterosuperior plate provided the highest level of union and also the best functional outcome. This study only was an Indian study, only treated conservative patients, no operative, and 94% healed, so it's higher than the other rates, but only 49% reached a very good result. And they found that the ones that had shortening less than 1.7 centimeters and angulation less than 22 degrees did well. Other than that, had a poor outcome. So we know that malunion is caused by displacement, more than 2 centimeters. Earlier studies, McKee, have shown that, but also confirmed by neuro studies that if you have more than 2 centimeters, you get scapular dyskinesia, 6 scapula, and poor outcome scores. Other studies have looked at percentages rather than a fixed 2 centimeters, as the clavicle is different sizes in different people. So they said more than 10 centimeters will cause dyskinesia and problems in the shoulder girdle. Non-union is higher. It depends on the site of the fracture. So you know that lateral third is worse than middle third. Displacement, we've talked about it. Comminution causes non-union. Females and of course smokers lead to higher rates of non-union. So you should consider that when you're in your decision making of operative versus conservative. So other studies have looked at the cost effectiveness of operating versus non-operative. And in the US, this study looked at not just the hospital expense, but the total expense surrounding the fracture. Surgery was $10,000 versus non-op, which is $8,000, surprisingly high. And the leave was shorter duration than the operative group. Another study was done in Belgium, but they only looked at the surgical part or the hospital part, and they found that it's almost 10 times the cost to operate than the non-operative group. And the most important part in the cost was the length of stay in the hospital. And the things that increased the length of stay was the degree of comminution, whether it's the delayed surgery or revision surgery or infection. These are the most important ones that affected the length of stay. Don't forget, this study looked at 7,800 clavicles and 12.7% required hardware removal. So sometimes it's in the back of our mind, but we don't appreciate the amount of plate removal, hardware removal that's needed. So this study, 12.7% required that. So always communicate that with your patient in the decision-making also. Of course, females are the commonest. So the verdict for this is that surgery is definitely better for the rate of non-union in adults, not in adolescents. And it gives slightly better function if it heals than non-operative. But of course, it's more expensive and it's more hardware removal. So in summary, when you think about clavicle, midshaft clavicle fractures, at least go for 2 X-ray views, possibly a CT if in doubt. You have the different factors that will decide whether it's operative or non-operative. We know that displacement more than 2 centimeters or 10% will give you a poor outcome. Remember the important figures of 11% non-union rate and 12% hardware removal. Thank you for your attention.
Yeah, my question was, you were mentioning that many people take only 1 X-ray, and I was wondering about the rationale for taking 1 X-ray only.
This was in the results of the poll we did before the webinar, so we're just asking the people about that, and they did it. I think a lot of people just look at the clavicle as 1 view, but this is obviously not the right thing to do. As most of us, we need 2 views for everything, or sometimes more, but this is at least 50% of the people we polled show that they only take 1 X-ray view. We will proceed with the next talk by Simon Lambert from the UK, and he'll talk to us about implant selection and positioning.
Thank you, Hatem. I hope you can see the title slide.
Clear.
Perfect. Well, thank you very much indeed. I'm going to introduce some ideas in the next 15 minutes that may be slightly new, but they build on what Hatem has already described so nicely in the clavicular fracture scenario in the middle third. So I'm going to talk mainly about middle third fractures, not about the lateral fractures or the medial fractures, but the common clavicular shaft fractures. Why do we plate a clavicle? You've heard this now from Hatem. There is increasing and probably clear evidence now for the efficacy and value to patients of plating the clavicle for particular groups of people at particular times in their lives. And that's beginning to get quite well established as a theme in this decade. But reoperation rates are clearly important, adding to cost, adding to potential morbidity, and taking patient time. And it's this business about being aware of the implant, not necessarily the implant giving rise to skin problems or pressure problems, but certainly the patients are often aware of the bulk, the contour, the outline, and the cosmesis of the plate. It's more, let's say, common for plates to be removed in certain parts of the world where there are certain cultural requirements to have plate removal, but it's still an important consideration. And that's why we consider the current type of plates for clavicular fracture management to be less than ideal, in the sense that most plates are either visible or palpable and cause patients concern. It was based on that sort of idea that we, some 6 or 7 years ago, started looking at what it was that a plate on a clavicle needed to be. And you've heard about the predilection for antero-superior plates, which appear to give an advantage in terms of union, and only a very slight advantage, but there appears to be. But there are strong views around the world. There are people who say, I only do superior plating, or I only do anterior plating. And then the majority of us say, well, I do a little bit of both, and I spread my hedge my bets a bit, and I do antero-superior plating. But that's, of course, predicated by the clavicle plate design. And there are families of clavicle plates out there, all of which purport to give certain attributes like stability of fixation, like bridging, and so on and so forth. But none of them, until perhaps we thought about it, tried to emulate a pathway along the border of the clavicle to which there was no soft tissue attachment. And so we developed this idea of the implant preferred pathway, where if you could find a bit of the clavicle which did not have muscle or tendon attached to it, that would presumably have better chance of preserving periosteal perfusion and therefore enhance the rate of union, which is interesting when you consider the slightly higher union rates with the anterior superior plates. Well, colleagues in the AO Research Institute in Davos developed a statistical model of the clavicle using CT scans of 174 clavicles, and we developed some modeling. And I'd like to show you a brief video which explains
using
that.
The process of cylindrical parametrization, Lucas and Hans-Rudi Moser produced 3D models of the largest third, the smallest third, and the central third of the group of clavicles. Each clavicle has a smooth area where the least amount of soft tissue injury would be created if a plate was placed in this region. We call that the implant preferred pathway, or from a computer point of view, the region of interest. For each size of clavicle, a model of the mean implant preferred pathways was generated. For the largest set, for the central set, and for the smallest set of clavicles. If we then compared the implant preferred pathways of each group of clavicles, we could see that if we matched the medial anticurve segment, and they matched well, then there would be quite a variable lateral retrocurve segment, matching clinical experience when we base our clavicular plating on a medial segment. If, on the other hand, we make a clavicle plate so that the central segment is constant, then we have differences in length medially and complex curvature laterally. Therefore, we have to have more plates for any given situation. On the other hand, if we match the lateral retrocurve domain or segment, and they are remarkably similar, then the only difference is in length on the medial anticurve segment. Therefore, if we accept that the implant preferred pathway for a clavicle plate is constant in the lateral segment, has comparable twist in the third fifth and second fifth of the clavicle, then all we need to adjust is length. Therefore, we might actually find that we need fewer clavicle plates to match any clavicle shape, rather than have complexity in the lateral domain.
So that was very interesting. And here is a graphic model of the clavicle seen from the acromial end, looking towards the medial side, with the average implant preferred pathway in dark gray and the perpendicular to the tangent of that pathway showing the twist. And that twist, as I mentioned, was pretty constant, so that we could say that over the length of a plate or length of an implant preferred pathway, let's say from lateral to medial, there was a region where the rate of change of twist was greatest. And there were regions where twist was not quite so altered. And that was very important because what that does is to focus us on the starting laterally, where things perhaps are more constant than we thought. Our thought processes are that the lateral side is complicated and variable because we start medially or centrally. But if we actually start laterally, all we have to do is to change the medial length. And that has implications for considering fracture plates. If at the bottom you consider the clavicle as thirds, and then consider the clavicle in fifths, the twist, the maximal twist, is basically done by the junction of the second and third fifths from the lateral side. And that has an implication because if you have a plate that is designed for the middle third of the clavicle, like most plates are, and most clavicle fractures said to be in the middle third are actually towards the lateral side of the middle third, actually at the junction usually between the second and third fifths. So in this model, about 6 centimeters or so, maybe 7 from the lateral end, then that central third designed plate will not cover in a balanced way the real clavicular fracture problem. And that's why if you take a plate designed for the middle third and shift it laterally in order to have balanced fixation, it doesn't fit either medially or laterally. And that then forces us to either fix badly or have to spend a long time contouring the plate. So why not design a plate that is basically balanced for the real group of fractures that we treat, not just the classic concept of the middle third. And here's why, because that region of maximal twist is where a middle third based clavicle plate has to be contoured maximally, where it is very difficult to do so. Whereas if you design something that takes into account that twist, then you've already got the plate you need. And if you start laterally and consider balanced fixation by extending the plate length medially, we then have a much more straightforward situation. So this idea that we're thinking about clavicular fractures in a slightly more morphologically accurate way, and then considering some pretty clearly regular morphological parameters, we can change our plate strategy. And instead of saying, well, I do anterior or superior, or sometimes anterior superior, I would say, we could say now, I'm going to have a plate that starts basically laterally, and I'm going to have a plate long enough to have balanced fixation medially, accounting for the twist in the second and third fifths. So it's the medial length adjustment from a pretty basic common denominator lateral position that we're beginning to design. And here is the first of a new generation of clavicular plates. And this is a case kindly supplied by Dr. Martin Jaeger, one of the team who's designed this system, of this clavicular fracture, which in the AP view or the 30-degree cephalic tilt view does not give you the true reflection of the position of the fracture. Whereas when you see the fixed and final result, you can see that this fracture is more lateral, or it's in the middle third, but it's more towards the lateral side of the middle third. And here's the plate that has not been contoured and is, of course, quite a long plate, and starts with the fixation laterally, and balanced fixation has been performed in a very nice way indeed. So when you come to consider both the choice or the implant selection and position of the implants, I'm going to suggest to you that our thinking has to evolve a bit, and we should reconsider the fracture patterns as being towards the lateral side of the middle third, i.e. somewhere between the second and third fifths of the clavicle towards the lateral end. Whereas before we thought that the lateral retrocurve was actually very variable, that was because we were basing our fixation medially first. But a statistical modeling analysis suggests that the lateral retrocurve is pretty consistent, whether you're a tall, broad-shouldered person or a small, narrow-shouldered person. That group of clavicles came from Japan, from Innsbruck, and from North America. So we feel that there is a breadth across various body sizes. The medial anticurve is where the length of the clavicle changes in the majority of cases, and there is a regular, predictable, pretty constant twist, maximal in the second, running to the third, fifth, which speaks to our upright stance and posture and our, let's say, anthropological origins. So plates that are based on and designed for the middle third philosophy cannot fit the true fracture patterns and make it difficult for us to do so. And I'd suggest that a fixation strategy that you might think about and adopt is to think laterally and choose your plate that gives you a balanced cantilever resisting pull out and bending of the plate medially. Thank you very much indeed for your time today.
Thank you very much, Simon. That's very interesting and always stimulating to the mind to think about new ideas and new stuff and how to approach things. So we have a question actually from Terry. He's asking why 2.7 millimeter plates rather than 3.5?
It was felt that we should be able to distribute screws better within the rather wide variety or range of clavicular diameters using the 2.7 system rather than the 3.5. And of course, one can get out of plane fixation, which is much better at resisting pull-off, particularly with the new VA angle screws. And in benchtop modeling and laboratory testing, the current 2.7 plate is considerably stronger and resists torsion than the LCP, and certainly vastly better than the Recon plate, which was much more adaptable, of course. So we felt that there was a inferiority of the 2.7 system over the 3.5, but a benefit in terms of screw distribution.
Okay, thank you. There's another question. Chris, do you want to go ahead?
Yeah, I wanted to find out. So it looked like at least on the X-rays that you showed that you did some kind of bridge plating. So my question would be, what do you do if there's more comminution? Are you trying to get the medial plane, or are you just bridging?
No, this system does have combi holes in it, so you can apply a compression to a simple A-type fracture. We absolutely felt that people should be free to choose the style of fixation if they wished. So yes, you can certainly apply monopolar or bipolar compression if that's what you'd like to do for an A-type fracture.
So we have another question, Simon, from the audience. Is it better to fix lateral first and then check the position?
Yes, I think what I would say is what we've got on the systems that I think it's not just AO, but other systems too, are K-wires with little balls on them, little blocking balls on them. So what you can do is to apply the plate, put a K-wire with a little blocking ball in it to fix the plate where you think you ought to be laterally, apply the plate medially, do a reduction, and then do another K-wire with the blocking ball medially. So you've got the medial aspect of the plate central on the clavicle. And if then the clavicle follows, as it ought to, the shape of the plate, and this particular system comes now with 3 sizes of shaft plate, which is in relation to the patient's height, which is directly proportional to the patient's span and therefore the clavicular length. So we can choose that preoperatively. Then you've got preliminary reduction, and then you can start to fill your screw holes.
Okay, so we've received a couple of questions for my first talk, but I want to forward them to the panel to get the different views. One of them is regarding Terry, I'll forward that to you, regarding the displacement or the 2 centimeter displacement. When you see you have mid-shaft clavicle fractures, is that in any direction? Do you consider it axial, AP, or which direction do you measure that?
Thanks for the question. For me, it's the maximal displacement. So it's really hard to judge how distracted the fracture is, because that will change depending upon the angle in which the x-rays are taken, caudal versus true AP. For me, it's just whatever view shows the maximal displacement is what I would consider to be the sort of the go-to measurement. A lot of times it's more of a gestalt when you look at the x-ray. Like you look at it and you say, oh, that's really displaced. And so it's not that common that I'm actually going to get out a ruler and measure it. You just kind of look at it and say, yeah, that's really displaced. And you look at other ones, you say, well, they're pretty close together, so that'll probably do okay without surgery. But to answer your question, it's the maximal.
Okay, thank you. So another question, which I'll forward to Frankie. And so the question is, after you try to reduce it, if you're going to treat the patient conservative and you put him in a sling or maybe with a slight traction, how do you assess post-production? Do you just do an X-ray or do you do CT? What's your protocol?
Yeah, in my practice, I think I just repeat the X-ray. Usually we wait initially after the fracture. A lot of patients, they have muscle spasms, and then after 1 or 2 weeks time, when the patient is more relaxed, then you get a better AP, and sometimes we call it the clavicular AP, which is at an angle about 20 degrees to the normal AP, and then you can see it much better, and then you can appreciate the displacement. But many a times, I mean, the decisions whether to carry on doesn't depend on what the post-reduction X-ray looks like, because we know that the reduction achieved by the non-operative mean is only minimal. So it's a matter whether you will stick with it because you believe that it will go on to union.
Okay, great. That sounds good. So I think with that, we will move on to the next talk, and that will be by Frankie Leon, and that will talk, you tell us about the lateral clavicular fractures.
Okay, so lateral clavicle fracture. And I think what we see here is some classical methods that we tried when I first entered into orthopedics, and then maybe after the first 1 or 2 years, I received this case, and the senior taught me to use this transacromial K-wire and tension band, which works, actually it's pretty okay in this case. Then comes along the LCP. We know before the anatomical plates, which I think Simon has beautifully demonstrated the complexity. I think we can, for some fractures like this one, we can just stick with rather simple LCP, but of course you can only have 2 screws, which is not enough, as you can see. And then for more comminuted fractures, which is we often see, then surgeons have a problem using a standard LCP, and they thought about we can put an orthogonal fixations with double plates, and have some experience with using double plates, but I think it really doesn't work that well. I think if the fracture is too comminuted for plating, then it really doesn't work. And then there comes about the transacromial K-wires, and also come the suture anchors that a lot of the sports surgeons or shoulder surgeons like to use. So the real question for me is it a real issue to me? I mean, these are they really so problematic? Because I've also seen a lot of cases in my clinic when the patients come being referred at about 2 months' time, when the treating doctor said they have a non-union. But when I take a look at the X-ray, there is a gap there, but the patient is already having painless motion in the arm. So some of those are really not so problematic. Some of the facts about this fracture is that a delayed and also a non-union is actually quite common for a completely displaced fracture, about 40%. And even if you have a minimally displaced fracture, you don't fix it, it takes a long time to heal or develop a fibrous, painless fibrous union. And all these fibrous union, they're often, we call it totally asymptomatic, and the patients can have full range of motions at about two to 3 months time. And we often said that there could be comminution, and the very small piece here presented what we call technical challenges because of the comminution and the poor screw purchase. That if you fix it, sometimes the screws get all loosened, and then the patients actually have a plate sticking out, and you actually create more problems rather than fixing the fracture and helping the patient, because plate sticking out is really embarrassing, which I have developed in a couple of cases for my own patients. Is really embarrassing. So let's take a look at the natural history of such lateral clavicle fractures. Actually, if we take a look at this published in 93, okay, nearly 30 years ago, we have more than 100 lateral clavicle fractures being followed an average of 15 years. And at that time, because they don't have the adequate or strong fixation, most of them are actually asymptomatic, and only like 15 or less than 15% has moderate pain. There are 10 non-union so-called, but 8 are asymptomatic. So these may give us some thoughts whether what are we doing trying to fix these fractures. So let's take a look at the modern indications of fixing the lateral clavicle fractures. Now we use the near classification. We still have to go back to the usual, our good old friend, the X-ray, the AP X-ray, and then you take a look at the type. The type 2, where you have a more significant displacement. Either you have it partial CC ligament rupture, or the fracture occurs medial to the CC ligament. The fracture is widely displaced, and then you may have a problem, so-called the widely displaced fracture. So there is an indication for operative treatment. And then the so-called type 5, where the piece of the CC actually still attached to a triangular wedge fragment. And then you have, again, the wide displacement. This, again, is an unstable type. So for the treatment of a lateral clavicle fracture is that we can choose a non-operative management with just an arm sling, or the so-called rigid fixation. We did a poll before this seminar, and a lot of people like to use the hook plate. But we also have the lateral clavicle locking plates sparing the AC joints coming along. And some will just use CC, somewhat like a Bosworth screw, the CC screws, which are so-called rigid fixation. The sports surgeon, however, took another philosophy in fixing these. They can just use a transacromial K-wires, a tension band, a suture anchors using a tape, Dacron graft, or, for example, a tight rope, which is very common among the sports surgeons. All these may also work. So let's take a look at some of these cases. This is a case where you have a choice of all these. Is as you can see, a type 2. And we fix it with a lag screw and also the good hook plate. We will remove it at 6 months' time when we have the initial bone healing. But during the application, of course, we know we have to adjust the angle of the hook, which is a must, not in a certain percentage, but is almost a must in my hands. I think we always have to adjust this. And then also, if you take a look at the hook direction for the AC joint, is actually if you align the plate along the clavicle, the hook is actually pointing backwards, which is not so correct. So if the correct position to be underneath the acromion, then it is actually sticking off. So if you have a lateral clavicle fracture, the hook plate may not be able to have enough purchase over the medial. over the medial side. So that's the biggest problem if you want to fix a lateral clavicle fracture with a hook plate. Oh, that's why a lot of these, we also have to change the direction of the hook. So instead of pointing it too posteriorly, we have to tilt it a little bit pointing towards the acromion. You can do another self-made bend in the hook itself in order to fix such a. So afterwards, very often we have to fix it underneath the acromion, pointing in the correct direction. Again, before we moving medially and then pressing it along to the plate. And this one also fixed very nicely, and it healed at removed at about 1 year's time, and you see very nice because it's bony union. This is some more painful cases done in my hospital. A 76-year-old man. We initially thought we just manage it conservatively, but the patient strongly requested for a plate because he thinks it's very painful. So and there is a little bit of skin impingement, as you can see. So we fix it with a hook plate, but only at about day 2 weeks time, we heard the patient heard a crack at the right shoulder, and it shows peri-implant fractures. Possibly there could be some K-wires or previous drill holes around that area. So it broke the bone, just broke along that track. We discussed with the patients, and this time he's not so insistent, so we suggest him to have a non-operative treatment for this. So it actually heals up, and at the end we have to remove the plate, and this is the end result. So if you compare hook plate versus the so-called anatomical distal clavicle locking plate, some early papers coming out shows that for the locking plates, it's the problem of fixation, the loss of reduction, whereas for the hook plate, it's the hardware impingement and again, some loss of the reduction. Problem with the hook plate, the peri-implant fractures, again, has been reported quite a bit in the literature, and most of them were treated non-operatively. So another case, and if you take a very careful look in this, you can notice that this is more like the type 5 that we talk about. These patients have a very painful shoulder. Again, when we take a look, it doesn't look that displaced, but the patient complains a lot of pain. And when we take a look, we classified it into type 5, and that's why we go ahead with fixing it. And for this one, we also use more or less like a hybrid. We use a strong tape to really, like a cerclage, bind the whole things together, the wedge down there, together with a protective suture anchor, and then fix it with a anatomical lateral clavicle plate. So all these are more like a hybrid fixation for this. So this at 2 months' time, you see a very nice healing for this fracture without spanning the AC joint. And I think it works pretty well, at least in the younger patients with good bone quality. So it's more like a combined suture anchor and also the taping and together with this lateral plate. So there are some other spot surgeons in my hospital. They preferred just using the suture anchor together with a transacromial K-wire. This is a 60-year-old man being fixed in this manner. The spot surgeon shared with me some of his techniques, which shows pretty well. So at post-op 6 weeks time, the patient doesn't have any pain, but as you can see, it actually goes on to have a fibrous union. Last but not least, this is more favorable type in the younger patient in my hospital, the so-called lateral clavicle fractures. We fix it with a hybrid kind of a fixation. We fix it with an anatomical lateral locking plate together with a CC fixation with a suture anchor. So in summary, I think that you take a look at the lateral clavicle fractures, you really have to choose which fracture to fix. Not everyone needs a surgery. And I think the anatomical reduction is actually may not be necessary for good function. Some have asymptomatic fibrous union. And the rigid fixations, particularly in the old osteoporotic bone, has a high risk of peri-implant fracture, so be very careful. And in the younger patients, I think we prefer the so-called hybrid fixation with the anatomical plate together with the suture anchors or a fiber tape to just tie the bones together. And the flexible fixations may be more preferable in the older patients if it's really indicated. So that's end my talk here. Thank you very much for your attention.
Thank you very much, Frankie, for this very interesting talk. So we have a couple of questions. One of them is, how do you predict the amount of fragmentation in this lateral third clavicle? Because I mean, you talked about the hybrid fixation, and obviously that will need some purchase in the lateral for the superior plate. So how would you predict that lateral comminution?
Yeah, I think in my hospital, we routinely get a CT scan. I understand it may not be available in every hospital, but or in every cases or clinic. But I think in really suspicious case, I strongly advise you get a CT scan to have a better preoperative assessment. Because even with a hybrid kind of fixation, sometimes you can have a very poor purchase. Because you are fixing the amount of cortical bone that the whole lateral fragment may be split in this manner. So you are only fixing more like a unicortical fixation, which is not good enough. So okay. The simple answer, I get a CT scan. Yeah.
CT always, okay. We have another question, which is about non-union. So if it's a delayed non-union, sometimes this lateral fragment sort of is, resorbed a bit. Do you ever go to excise it and just try to do a CC plus possibly AC reconstruction?
Yeah, I think that's another problems. We don't, I mean, with the modern fixations, we don't have that lysis occur from the poor fixations that you require some kind of salvage procedure. My experience with the excision of the clavicle, the lateral end of the clavicle also doesn't work that well. Only in the neglected cases, I do some kind of also the ligaments augmentations, or even have a graft to reconstruct the CC. And in that case, I excise a little bit so that there will be no, at least the joints, the arthritic joints or the bone will not be touching one another. But I think the pure excision, it doesn't work. So you have to really augment it with a strong graft, or even a tendon graft.
Okay, I think the last question is sort of a combined from two questions. It brings me also to a point I wanted to add. It's from the audience. It's two of them. When do you prefer? Do you do a lateral third plate, and when do you prefer a hook plate? And the following question, which I think you'll answer in the same answer, is what do you do when you have a fractured coracoid? Also,
right. I think that's a very good question. I mean, the problem with fractured coracoid sometimes, which is quite difficult. And I think we also have combined cases where you also have an AC joint. In a very severe injury, you have AC joint, lateral clavicle fractures, and also sometimes even the coracoids have fracture. All those are terrible, and I think you really need to protect your fixation. There's a high chance it may fail. Usually combine a hook plate with a more like an anterior clavicular plates in order to fix it, and together with fixation, possibly with a screw, if possible, with a screw to fix the coracoid as well. So combine everything. Even those who have a high problem of implant impingement, because they may get a little bit loosened sometimes. Yeah. How to choose between a hook plate or lateral? I think it depends. I think in younger patients, I tend to spare the AC joint. In older patients, I tend to use the hook plate a little bit more if it's because I don't think the small clavicular end would be able to hold any screws.
Excellent. I think I'll just throw one question to the whole panel because you talked about the hook, the hybrid, or just the lateral third. I know we're talking in general, but for myself, the hybrid is my preferred technique. So if I can ask Simon, Terry, and Chris, what's their preferred technique for the majority of the cases?
When looking at the pathology, it's often like a type 4 injury, in fact, with periosteal elevations. So I prefer, for the very distal ones and for multifragmentary ones, a hook plate, and I suture. I bring the avulsed periosteum with ligaments up around the clavicle with a cerclage suture. So I try to do direct soft tissue repair plus an internal brace, if you like, with the hook plate. And I'll repair the acromioclavicular capsule if that is torn as part of the lateral fracture.
Okay, thank you. Terry?
Pretty much the same for me as what Simon has said. I find that I really need the reliability of the fixation of the hook in order to feel secure with it. I really like the idea of sutures through the CC ligaments and bringing them up and tying them either under the plate if it's possible or over the plate. But just helps to bring that avulsed fragment of bone up into apposition so it has a greater chance of healing, I think. I mean, we all feel that that's helpful. But that's what I do. I just find that a superior plate, even with the divergent screws, never gives you that warm and fuzzy feeling that you've got enough fixation. And I think those are the ones that pull off. So in that situation.
I agree. It's as Frankie has mentioned, that's why my fixations are hybrids. I'm not a very big fan of the hook plate. So it's the plate alone, I think, is very disadvantaged. But adding that CC augmentation with an anchor, with a suture button device, is that really gives you that relief. So that's my view. Chris, what do you usually do?
I can make it quick and dirty. I do the same as Terry just said, pretty much the same.
Excellent. Okay, thank you very much for that talk, Frankie. I think we'll move on to with Terry. He's going to give us a talk about how to manage mal and non-unions of the clavicle.
So thank you very much, Tam and Chris, for asking me to participate in this this symposia, this webinar on clavicle problems. I've been asked to talk about non-unions and malunions of the clavicle, and it's quite a pleasure to talk about this. So as it relates to conflicts of interest, I have none as it relates to this particular topic. And I want to thank Mike McKee, who's a former colleague of mine, for some of the illustrations in the talk in the AO archives. So as an overall introductory statement, with non-unions and malunions, we really don't see that many of these anymore, because there's the trend towards early open reduction and internal fixation of the displaced clavicle fractures, all the things that we've heard about so far. So some non-unions and malunions still do occur. They're largely grouped into the idea of no prior surgery, and those are the ones that are widely displaced, low-grade infections or a poor biological host, or those that have had surgery but it hasn't worked out so well. There's either technical or non-technical failures, or perhaps low-grade infection. Let's start off with a case example. This is a police officer who has had a gunshot wound to the chest. You can see the bullet fragments here and here. And there was an subclavian artery injury. It's hard to pick it up, but there actually is a clavicle fracture. So we became involved in the fixation of this clavicle. The vascular surgeons, basically, you can see from the staple line here, they extended the wound. They fixed the subclavian artery with a graft. But during the process, they stripped out the clavicle quite a bit, pushed it out of the way to gain their exposure, and then we were called in to put it back together. You might note that this is a 2.7 reconstruction plate. This is not a pre-contoured plate or one that's specifically made for a clavicle. Within a couple of months, his arm did well from a vascular point of view, but the plate broke. And we know that this plate's used in sort of a bridge plate fashion here, although we do see some interfragmentary lag screws applied. So the plate broke and he was symptomatic. So this required a revision. This was a non-union. plated, bone grafted, and he went on to heal uneventfully. The revision implant was a standard 3.5 LC-DC plate. So what are the problems with non-operative treatment? Well, the two problems are already been talked about a little bit, non-union and malunion. And those are the topics that I'm going to address. What happens with a non-union? Well, most commonly it's pain. It's the adducted, shortened, and protracted shoulder girdle where the arm is sort of turned inwards like this and droopy. And then the concept of thoracic outlet-like symptoms. The malunion, a lot of this relates to deformity and cosmesis. People don't like the look of their shoulder. Their shoulder droops, the clothing falls off of the shoulder. They don't like the bump. Patients complain of weakness of the limb. Again, thoracic outlet syndrome symptoms. And then, of course, there can be pain associated with a malunion, but I'll say this again many times during the talk, be quite wary of this as your primary indication for doing something. Non-unions. So this is a clinical example of a non-union. A little bit of bone is forming between the bone ends, trying to heal, but it never did heal. And this is typically what it looks like when you expose the fracture non-union site. The ends of the clavicle are overgrown. The canal is sealed off by bone. There might be some callus around the fracture, a non-union site like you see here. And you can see this very dense fibrous scar tissue, which bridges the non-union. Sometimes you get a true synovial pseudarthrosis, but more commonly it's a fibrous non-union with this really dense, thick tissue that's all matted together. And you always have to keep in mind that underneath of this, these ends of the clavicle, there's some pretty important structures that you have to be very careful with your dissection around. We've heard a little bit about this already, but just to review the history for a moment, the earlier series talked about 2,200 clavicle fractures by Charles Neer, only 3 non-unions. And C.R. Rowe in 1968, only 4 non-unions and 566 fractures treated closed. However, the results didn't match our clinical experience. All of us that have been in practice for a few decades now know that those numbers aren't correct. There are a lot more people with non-unions of the clavicle than those series told us. And the people that started to pay attention and publish on this began with Dr. Hill, published in 1999, where he talked about closed treatment of displaced middle third clavicle fractures giving poor results. And he found 15% had non-unions and shortening of greater than 2 centimeters with the displaced middle third fractures. Dr. Robinson had a seminal paper at the OTA in 2003. He looked after 868 patients over 4 years. Non-union rate overall was only 6.2%, but if they were displaced or comminuted, i.e. that classical displaced comminuted midshaft clavicle fracture, the non-union rate jumped to 21%. Other people like Mike McKee have looked at it, and this gives us a pretty good idea about the risk of non-union with displaced midshaft clavicle fractures. It hovers between 15 and 20%. So non-unions of the clavicle fractures does occur, especially in the displaced group. And so if you decided to manage the non-union surgically, if there's appropriate indications for it, you really do have to image it properly, and I'll probably get a CT scan on almost every one of them. What are the principles of how to manage the non-union? Well, you need exposure. This is not microsurgery. This is not minimally invasive surgery. This, in my opinion, is maximally invasive surgery. I'm a bit old school this way, but I feel that you do need to see it in order to deal with it. So the exposure is, as we've seen here in this photograph on the right, you have to take down the non-union. You have to mobilize the ends of the clavicle. So that involves dissecting under the spikes of bones, both ends, with a 15 blade or a very sharp, small periosteal elevator. And I often use a towel clip or a lobster claw on the clavicle to actually lift it up as I'm working underneath of it to clear it. I have to be able to mobilize the ends to get them reduced. I'm not going to fight that massive scar tissue to try to get it to hold together because it's not going to work. You have to debride the non-union. All that fibrous scar tissue has to be taken out. A rongeur is a very good tool for doing that. And once you've got your bone ends exposed, I usually shape them either with a saw or with the rongeur, so I get nice opposing ends that I can shape and I can get bone-to-bone apposition with. And then I always drill the ends of the bone to open up the canals, curette to enlarge that somewhat so that I get bleeding healthy bone. Whatever bone you take off can be set aside, like this bone here, as local bone graft. Reduction and fixation, the choice of implant, in my opinion, is very important. I think you need a fairly strong implant for this. This is not something you can deal with a small reconstruction plate. It has to be a strong implant. Clavicular pre-contour plate is great. An LC-DC plate is fine if you twist it, but it takes a bit of work to make it fit. Then comes bone grafting. If you have a lot of local bone graft, that might be enough. If you have a segmental defect, an iliac crest graft may be better. I don't really use allograft for this. Jesse Jupiter came up with this concept. He's published it again in 2016. The usage of a sculpted iliac crest graft where he creates dowels on either side, these little pegs to sit in there. And this is really when you have segmental bone loss in the midshaft clavicle. He had good results with that. There's this nice little study from 2015 that looks at local graft versus iliac crest graft, and the numbers are 92% healed with iliac graft versus 73% with just local bone graft. So the recommendation was to use iliac crest bone graft for the majority of these. However, in my own personal experience, if you've got no major bone loss and you can get good bone-to-bone contact, and there's quite a bit of callus around there when you take it all out, that's sufficient as a local bone graft, and it usually works. For me, the fixation is the most important part. So that covers the non-unions. Let's talk a little bit about malunion. And this would be a clinical example of a young woman with significant malunion of her clavicle. And the patients complain of that sick scapula syndrome or sick shoulder syndrome, deformity, weakness, and some thoracic outlet symptoms. You can appreciate the amount of displacement here, the foreshortening of the shoulder girdle on the right side compared to the left. It's this idea that Mike McKee talks about, a shoulder ptosis, where the whole shoulder is sagging, clothing falls off of the arm, and they get all these symptoms as I've described. Mike McKee talked about this a long time ago, around 2003, 2004, when he reported on the first 15 patients that they looked at, and these were the typical complaints: scapular dyskinesia, fatigability, weakness, pain with repetitive or overhead work. Keep in mind, it's not necessarily pain at rest. That worries me when people have pain at rest. Neurological symptoms, and of course, cosmetic. And I think that the cosmetic indications are often what brings people to see the specialist for something to be done about this. And this would be an example, another clinical photograph showing that droopiness of the shoulder. What we see here is if you draw out the size of the thoracic outlet, it's considerably narrowed on the injured side. And it makes sense that these patients could get thoracic outlet symptoms from the malunion. These are photographs of Mike's from a case. You can see it's healed with the malunion, and then he goes ahead and cuts the bone. And if I ever said to Dr. Tile that I was going to cut a healed clavicle, he would kill me. But that's what can be done these days. We cut it and then shape the bone ends so that they meet properly, and then fix it in place. So this was fixed with a standard 3.5 LC-DC plate. Requires quite a bit of twisting to make it fit, but it generally works well. So in his early series, he had 15 that were treated with an osteotomy, plated. He used only local bone graft. 14 of 15 were subjectively better. They were satisfied that they had the surgery. The biggest change seems to have been the thoracic outlet syndromes, symptoms, which got better, and their dash got better. 1 didn't heal, and 2 needed hardware removal. One of my previous fellows, Claudia, did a nice little review published in 2018 about clavicle malunions. It was a review of all the case series. There was 29 studies, 103 patients included. So you can see there aren't a lot of these being done. 77 actually had an osteotomy. So we're talking about 29 studies, 77 osteotomies. If you do the math, that's just a little bit over 2 cases of osteotomy per series. So that's not a lot of evidence. Anyways, the complication rate was less than 6%, and there were sporadic non-unions. Most patients seem to be happy with the results of this procedure. But I want to emphasize that this is not something that we do routinely. Corrective osteotomies of clavicle malunions. You need very careful patient selection, and you have to spend a lot of time trying to figure out if this is the right thing for this patient. Most people don't need this operation, even with significant malunions. Final case to end with. This is a borrowed from my colleagues in Europe, a straightforward displaced midshaft clavicle fracture. This was treated with an IM rod concept and went on to a non-union with bending of the implant. You can see here, this is a pretty classical hypertrophic non-union, which is due to excessive mobility at the fracture site. And then that's revised with a straight plate, local bone graft, and went on to heal. So just to summarize, non-union is more common than it's been classically reported. Using traditional principles of how to manage an orthopedic non-union, we can usually get these to heal. You have to take a lot of time taking down the non-union, and usually it's advisable to bone graft, especially if you don't have a lot of local graft. Malunion of the clavicle is a distinct clinical entity which has reproducible symptoms. Sometimes union alone does not equal success. And there are some cases, again, very selected cases, that might well respond to an osteotomy. So thank you for your attention.
Thank you, Terry, very much. Do we have any questions from the panel? So I have a question.
The only
Terry.
question that
Okay, Chris, go ahead.
Well, the only question that comes to my mind is if you do an osteotomy, what do you tell the patient in terms of complications?
That's a great question, Chris. What I would say is that the odds are that they're going to want the plate out. So I would say there's more than a 50% chance you're going to come back for a second operation to have the plate out. I would say that the chance of a non-union is less than 5% with that. And then the other complications, the typical things with clavicles, the numbness of the chest wall and that type of thing. Those are the major ones that I would tell them.
Great. I think we had the pre-webinar poll, Terry, and it is surprising that only very little people or surgeons operated on a malunion, while considerable amount operated on non-union. So what's your view on that?
Well, I think that it just reflects reality, in my opinion. There are an awful lot of people out there that have malunions of the clavicle of varying degrees. And even though there are some symptoms from it, most people tolerate those symptoms fairly well and don't need anything done. There's the odd person that is not doing as well with it. And I think probably those are the ones where you have impingement on the brachial plexus, on the vascular structures, and they do get thoracic outlet symptoms from it. Probably those are the subset that will come to you wanting something done about it. But that reflects my experience. I've only done maybe 3 or 4 of these in my whole career, and I do a lot of clavicle fracture surgery. So it's not a common operation by any means. The non-unions for sure, because that's a real entity, a real problem.
I think that's probably similar in most of our practices, and strangely enough, that malunions, although patients come with complaints, they're not convinced enough to have the operation. So
yes,
but that's life. So thank you much for the nice talk. We've passed over 400 viewers now on Panopto, so it's nice to have everyone with us. We're glad that they're enjoying this. So we'll go to our last talk, which is also a very interesting topic by Chris Pape, which is about combined clavicular injuries, floating shoulders, and suspensory ligament complex injuries. So, Chris?
Well, thank you very much. I am extremely happy to share my information with you, and it's also very nice to see 400 people in this webinar. it just means that this topic, although it may seem so simple, important one. So I'm going to talk, seems to be fairly well defined, but the reality is that you have to look at several issues. And what you have is combined clavicular injuries. And the important issue is that you have to make sure you don't miss anything. So what I'm going to talk about really briefly is glenoid neck fractures, because they can be associated. Double disruption of the superior suspensory shoulder complex and scapulo-thoracic dissociation, which is forequarter amputation. And so these injuries, a lot of times they come with multiple other injuries, or if you have a direct blow, a severe blow to the shoulder. So as far as the glenoid neck fractures are concerned, there are 25% of the scapular fractures. And as I said before, it can be a direct blow or fall on the. This is why it may be important because and the type 2s and 3s are probably the ones that affect us quite a bit. And those are the ones that you can see along with clavicular injuries. And then the triple SC, it is. First of all, I think we have to have a quick look at it, because it is much easier to understand if you look at the anatomy. And so here is the anatomy. It's a ring. It's an AC ligament. The clavicle can be broken or doesn't have to be broken. Then the glenoid is attached in the acromion, and so this is pretty much if this is what you call a floating shoulder, and as we have heard before, it sets the patient up to nonunion, malunion, and other problems. The initial phase, they are frequently associated with neurovascular compromise. Many of them usually have to be treated surgically because of the displacement of the glenoid, or potential instability, because the entire shoulder can be sagging. Here is some retrospective review of 20 cases where some of them have been treated non-union, which I found rather surprising, and pretty good results in the majority of cases. And so some of these injuries can be treated non-operatively. I think that we have become much more aggressive recently to fix them, especially since the locking plates have been becoming available. And then as far as the scapulothoracic dissociation is concerned, it's a traumatic disruption of the scapula from the posterior chest wall. And many times it's associated with a clavicular fracture. And so my main issue is that you have to know about all these injuries and find out that they are somehow connected. It is also called forequarter amputation, which is closed. And a lot of times there's an arterial injury, as you can see on this on these X-ray right here, and an associated CT scan. It's a rare and life-threatening injury. You can lose your arm. It was first described in 1984, and the hallmark is the severe neurovascular injury to the upper extremity. I think the key publication is as you can see, there's limited information. The scapula is completely separated. A lot of times it's associated with the medial clavicle injury as well. Percent of the cases, according to this publication, and then separation as well. And brachial plexus injury in 80%, and partial in the rest of them. And the diagnosis, usually you have a massive swelling of the shoulder region. You have a pulseless arm, complete or partial neurologic deficit, and then the left. And even on the plain films, you can at least have a guess what is going on. If you, we have done, back then we looked at several SF36 and some other shoulder scores. And actually we found out that this is the original 3 different types. Type 1 being muscular, type 2B with a neurologic, and type suggested that probably number 4. And so I don't know if that's knows this quite better than I do, injuries. And if you talk about just as a floating shoulder only, you particularly have to look for the associated glenoid neck, the triple SC complex, and the forequarter amputation. So that's really important. Thank you very much.
Thank you, Chris, for this interesting talk. We had some technical difficulties there, but it's a very important topic, looking at these combined injuries and how to assess. So while we're waiting for more questions, we have a question for the last talk for Terry about the non-union. So how long do you wait before you decide that this clavicle is not going to unite?
Oh, usually you know it's not going to heal by about 4 months, maybe maximum of 6 months, but usually it's pretty obvious by 4 months it's not going to heal. That would be the usual period of time that I would wait. There's no point in dragging it out beyond there. And then that's when I have the discussion with the patient about whether or not they want to have something done about it or if they want to leave it. Doesn't mean I operate on them all at 3 to 4 months. I just begin to have that discussion with the patient that if you want something done, we should probably just move on and do it.
Yeah, very good. Okay, so another question, it's related, so I'll forward that to Simon, and it's related to the combined injuries. So when you have a combined clavicle scapular fractures, how do you decide on surgery? Which one do you go for? And if you're going for both, do you have a preference, clavicular scapular first?
Thank you. Chris van der Werken showed us that if you fix the clavicle only, the scapular neck fracture doesn't always indirectly reduce. He showed that quite convincingly a long time ago. And so if you're going to restore the lateral corner of the shoulder to get, as Mike McKee described, the ptosis back, then I fix both. So for me, as a kind of shoulder surgeon with trauma, I want the center of rotation of the shoulder joint to be pretty well the same as the other side. And to do that, I'll fix the clavicle first, because that's the cantilever for the lateral corner of the scapula. And if that then doesn't restore the scapular angle, then I'll do a second operation, of course, same time, but flip the patient onto their side and do a posterior approach, a Brodsky approach, and fix the lateral column. So my personal view is that if I'm going to fix one, I'll fix both, because it's logical in a way. And it means that I can actually get the patient moving very quickly, because once you've got stable fracture fixation, actually rehabilitation becomes very straightforward.
Very good point. So I'll forward the same question to Frankie and then Terry.
Yeah, thanks. I think, I can't quite put it as nicely as Simon, but actually I tend to fix both, basically the same line as what Simon said, but I think you hear the rationale, and I think just fixing the clavicle doesn't really reduce the scapula, and we often find that, and that's the main reason.
Terry?
I have very little to add other than just the idea of preparing yourself for the surgery. I think that some people just fix the clavicle because it's lickety split fast and you're done with it, but it doesn't really address the problem where as described beautifully by Simon. So you have to be prepared to
the end of this great webinar. We were so lucky to have such distinguished faculty. I want to thank Chris Pape for co-moderating with me, Simon Lambert, Terry Axelrod, and Frankie Leong for joining us and giving us the time and these great lectures. I want to thank SICOT Pioneer and AO Trauma for providing this great platform, reaching out to their members, and we look forward to more webinars and collaboration between SICOT and AO Trauma. And I'd like to thank Sofiane, who's been behind all the technical preparations, and SICOT head office for this. So thank you very much for your time, and please join us again for future webinars. Thank you, everyone.